All right. Hopefully you can all hear me. I'm going to end up doing my own introduction. So, hi, I'm Dr. Chapman, and I am at Children's Hospital Los Angeles. And as Dr. Gold hinted to you all, I'm also an internist. So, I'm a pediatrician, internist, biochemical geneticist. And we're going to talk about how adulting can be hard, right? And some of the things that they asked me to talk about is transition. And so, like, we usually think about transition as being, moving from the pediatric to the adult care world. But there's more to transition than that. And then I want to talk a little bit about the differences between pediatrics and adults, and we can chat about it. We're a really small group. We can actually chat. And then I'm going to talk a little bit about adult-specific issues with the homocystinuria. But I want to start out, life is a transition, right? From infancy to older age. And we never do this alone. There's always help. There's always someone that's going to help you with each of these stages. And there's a lot of adults sitting in this room because, adulting is hard. How many people would agree adulting is hard? It's hard, right? It's hard to make that transition. And the transition that most people think about is this: I'm moving from pediatrics to adult care. And, pediatrics, it's community involved, family centered. Adult care, you got to take ownership of your care, right? You got to be autonomous. You've got to ask for what you need. In pediatrics, the consent comes from the caregiver. In adult, the consent comes from the patient if they are able, right? Right? You guys have to agree. In pediatrics, there's a lot of support services. In adult, there's less support services. And they're like, Kim, what do you mean by this? Well, if you think about getting hospitalized in a pediatric hospital versus getting hospitalized in an adult hospital, what are some of the things that'll appear in your room? We have a dog committee that brings dogs into our house. That's a support system. It makes everybody relax a little better. Do you think the adult hospital down the road does? No, they don't, right? So, there's all these other things. In pediatrics, you get really long appointments, right? And you get a lot more monitoring. In adult, it's shorter appointments and a lot less monitoring. The time you have to get your blood drawn gets spread out a little bit. In pediatrics, it's simple as getting coloring books and gifts when you go to the clinic, right? When you become adults, there's no lollipops or stickers. In pediatrics, there's a lot of people that have state insurance. And then in adult, we start transitioning to federal insurances. And then pediatrics, the patient model is acute management, right? They're thinking about, you're getting this viral illness, da, da, da. In adult world, it's a chronic management, chronic disease things. So what makes the adult world also more complicated than the pediatric world are things like adult-specific issues. We're talking about higher education, employment, homemaking, balancing work and home. Intimate and platonic adult relationships. This is different than in pediatrics. And then reproduction, exercise, and then adult-related health issues. All right? As you become an adult with homocystinuria, that doesn't mean you can't have normal adult stuff. All right? Doesn't mean you can't have adult stuff. And one of the problems when you have a metabolic disease, and I see this over and over and over and over, is people start blaming your metabolic disease for something else. All right? So let's talk about a little bit, what does it mean to be an adult? So technically, legal adulthood and the legal age in the majority of the U.S. states is 18 years. When you turn 18, you are a legal adult. That means you are responsible. It is 19 in Alabama and Nebraska. In Europe, this could be as young as 16. All right? Medical transition to adult care starts at birth in reality, because we're always trying to set the table for our kids to be successful, right? And we should be starting by thinking about that at birth. But most of the recommendations for healthcare say 12 to 17 with completion by 21 years. You'll notice I'm kind of going like this. This is not 6, 7. This is, if you look at all the literature, this is what they say. How many folks have actually had their 12-year-old or when they were 12 started to get transitioned to adult care? Yep. Not too many. Decision-making support. So if somebody cannot make a decision according to legal, can they make a legal document decision? Are they going to need help? Are they going to need guardianship? Are they going to need help with medical decisions, money decisions, voting decisions? And keep in mind, if the legal age for adulthood is 18 or 19 in your state, then that thought process has to be done almost by the time people are in 18. Talk to your lawyers about exactly when that occurs, because I was in a state where they couldn't start until somebody turned 18, which meant there was a really scary time right after their birthday before they got guardianship. But in most cases, you can have that ready to go when somebody turns 18. And somebody that can't make medical decisions may be able to make money decisions and vice versa. So those are all conversations you have within your family. Getting ready for adulthood. We do it badly. 83% of youth with special healthcare needs do not meet the National Healthcare Transition Measures when we look at this. Time alone with a provider to speak to them without a parent or caregiver in the room. How many folks, that's supposed to start by the time you're 12. I'm really bad at this. I suspect other providers are. Provider worked with them to gain self-confidence or to understanding the difference in adult care settings. How many people got that? Providers talk to the patient about seeing adult providers. People do that pretty well because a lot of times pediatric hospitals cannot take care of patients that are older. And most parents don't think this needs to happen. So when parents were surveyed as special needs, they said, no, my child doesn't have to be at the doctor by themselves. And this is not even going to the doctor. This is some time alone with the doctor. And what are kinds of the things that we need to think about when those conversations have? Well, we talked a little bit about it in the family planning, but it's everything from, do you actually know the name of your diagnosis without your caregiver giving you promptings? How many people can name their diagnosis? How many could do it when they were 12? How many people knew what medicines they were on and how to call for the refills by the time they were 16? These are what the guidelines actually say. Now, the guidelines are terrible for individuals with special healthcare needs because they don't quite do the same range, but these are kinds of the things to think about. Let's talk about living independently. What do you have to do to be able to live independently? Well, doctors are really boring. We call these ADLs and IADLs, but ADLs are like basic surviving skills. Can you bathe alone? Can you dress alone? Can you toilet alone? Can you transfer from either a chair to, from bed to a wheelchair? Can you transfer from a chair to walking? Are you continent, or do you need to have changing? And can you feed yourself? The AIDLs are a little bit more complicated, and I like to think of these as being the real skills you need to transition off, or the you should probably need this before you go to college skills, right? Can you cook and do some sort of meal preparation? I'm not asking for a gourmet dinner. I'm asking for pulling it out of the refrigerator and being able to microwave it. Maybe being able to boil water without burning, although my husband wasn't able to do that, so that may not necessarily be a skill. Being able to do cleaning, basic cleaning, and laundry. Does everybody know how to do laundry? Shopping for groceries and essentials. Using transportation, that's supposed to be transportation. And I say using transportation because notice this is not can you drive, it's can you use transportation. Do you know how to call for transportation? Can you use public transportation? Are you going to get lost? And then managing your medications. Do you know what medications you're on? Do you know how to call your scripts? Handling finances. Can you balance a checkbook, even though nobody has checkbooks anymore? And communication. Are you able to call? Are you able to email? The next stuff is like higher education. We say higher education, but sometimes this just means more education or some education. So it may be college, it may be post-grad, it may be trade school. And then actually the other really important questions to ask is, do you want to go to more schooling? Do you need to? What do you really want? What do you want to do? What do you want to do when you grow up? This is when it really comes real, like you got to choose what you're going to do. And can you do it? Or can I do it? And then I have a note on military. So individuals that are on special diets, the CBS folks, You guys, for the most part, will not qualify to be able to participate in the military because of the specialized diet. And this is really important if you're thinking about future planning. Becomes really less of an issue in homocystinuria. Although I did disqualify somebody from the military, they were late onset, and in fact, they were in the military when I made their diagnosis of CBS. And they knew that when we had the conversation about the fact that they would disqualify. He was ready to retire from the military, so it ended up being okay, but just keep an eye about that may not be an option for everybody. Choosing is important. This is an adult thing. What can I do given my medical condition? Most folks cannot become professional NFL players. They just can't. They may want to, but they can't. What do I like doing? Everybody can ask that question. What do I enjoy? What really makes me excited? So even folks that may not be able to live independently can have a job, but it has to be something they like. Where do I want to do this thing? Am I going to live at home? Am I going to do it in my hometown? Am I going to move across the country? Where am I going to do this? And can I do what I want to do? AKA, is it realistic? I had a MMA kid that was a spastic paraplegia that wanted to play basketball. He was in a wheelchair. It was not realistic. And I looked at him and I said, well, have you ever thought about being a sports agent? And he hadn't. And so that is what he's going to school for. Employment. What can you do? For example, if you have trouble with physical activity, some jobs probably aren't for you. Will I need accommodations? So the federal ADA says if there are greater than 15 employees, it requires for the qualified individuals with disabilities, that's physical or mental impairment, limiting major life activities, to have accommodations that allow them to do a job they are qualified for. This includes time off for appointments and treatments, ergonomic equipment or assisted devices, and for those with vision impairment, large print access, safe steps, and hallways. If you have a limitation that would qualify you under the ADA, Americans with Disabilities Act, then feel free to ask for accommodations. You may not do it you may choose to not do it while you're being interviewed. But if you have a job and you are qualified for that job and there's greater than 15 employees, within reason, they should be able to give you these kinds of accommodations. And then the other question is, when you're interviewing, does this site have the things I need? If you're on a special diet and you need to maintain that diet in a refrigerator, make sure they have a refrigerator or make sure you can bring one in. Okay. Let's talk about homemaking. Cooking, grocery shopping, paying bills, paying taxes, laundry, cleaning, and minor home repair. These also are some of the ADLs. So as you become an adult, what are some of the things that just, come on, adults, these are the things that get hard, right? You're like, oh, do I really have to go shopping? I'm not really up to cooking today. What are we going to do to eat? Laundry. How many loads do we have to run this week? Those kinds of things. And these are all things that as we become adult that makes adulting hard, right? And they're the things I was sitting and I was thinking, what are the things that make adulting hard? And this is the list that I'm like, oh, these are the things that make it hard. Transportation. So driving is not something everyone can do. Individuals with poor attention spans, vision problems, and then physical issues can't drive. But that doesn't mean that they can't do transportation. Can you use public transportation? Are you in a location that has public transportation that can be available? Can you access buses? You can use access buses. You can use regular buses. You can use trains. You can use subways. You can use your feet. So think about all of those things as you become an adult. You can ride a bicycle sometimes. Um, but also, like, despite all those things where you're like, oh, these are make adulting hard. Remember, being an adult, you have life-work balance, right? Right? Come on. Right, life. So, what are the things you're going to do that are community building? And these are like activities and hobbies. What sports do you like? Do you like to watch sports? Do you like to play sports? Don't forget, as you become an adult, you have to find space for this. Do you like to dance? Is there a place to go dance? Are you going to take dance lessons? Do you like to sing? Is there a choir you can participate in? Knit. I'm a knitter, so do you knit? Is there a knitting shop? Do you like trivia? Is there a trivia play? What kind of travel? How do you plan for travel? Right? Because life isn't always work. And remember, work isn't the thing that you always do and go into the job, right? Work is also the homemaking stuff, the getting yourselves back and forth. But you also have to have life, right? What are the things you're going to do with life and how are you going to balance those? And these are sort of questions we all ask as we become adults. But they're also things that make life, being an adult, hard, right? Because you can get really distracted. And those who are parents, you can get distracted because your kids take all this time, right? And those who don't have children can get distracted because, life is hard. And those people that work a lot can get distracted. But, don't forget the fun stuff, right? Because that's part of what being adulting isn't so hard. There can be fun there too. Also, when you're an adult, one of the things that bring people joy is having relationships with others. And part of the idea here is to have to build relationships with others such that you have a shared purpose and a shared experience. And I always remind people that there's two kinds of relationships. Platonic, some of our friends, the people we hang out with, and lovers. And as an adult, you have both kinds. And it's really important we think about both kinds, right? Because that brings us joy in the family. And just because you have a homocystinuria doesn't mean you should not have both kinds. Okay? But also in adults, there's some things that we have to pay attention to. And these are things we have to pay attention to whether or not we're an adult with homocystinuria or not. But with homocystinuria, there's some issues that come along here. So alcohol. So alcohol can be problematic with our homocystinuria things because we can get dehydrated. Marijuana, there's something called emesis, post-marijuana emesis syndrome, where people vomit and vomit and vomit. That can be a problem if you have homocystinuria. Nitrous oxide, this is a real hard no, and everybody's like, what are you talking about? Unless you know what I'm talking about. So yes, it's a hard no if you go to the dentist, but it's also a hard no if you're sniffing it, because then you can make your homocysteine go up. We, in fact, hospitalize a number of individuals with nitrous oxide toxicity regularly now, and they're getting strokes because their homocystinuria or their homocysteines go really, really high, and they don't have homocystinuria. Smoking and vapes. I can't tell you that there's any literature or data about this other than it's not good for you. And then the not so legal substances, which as an adult, there's not a lot in the homocystinuria literature, but there's some implications if you get caught with it. So how do you stay safe with technology? This is becoming more and more of an issue. I don't know if any of you guys have gotten that text that says somebody has your information on the black web. Am I the only one that gets those kinds of stuff? Yep. So remember that you've got to look at data that you trust. And this includes things like dating apps. And for those of you who are younger, sexting, that's always visible to somebody. Don't forget to make sure you don't Venmo the wrong person. Right? And is this person who's reaching out to me somebody I know? And in some folks who have some decision-making challenges, This is not so easy, and this is where you need friends. So let's talk a second about sex and homocystinuria. So males and females are fertile. There is no risk for any of the homocystínurias to the fetus by having homocystinuria by itself. It is not teratogenic. And people would say, why do you say this? Well, for those of you who are familiar with PKU, elevated phenylalanines does cause harm to the fetus. There's not a similar thing seen in homocystinuria. It needs to be done with your metabolic team. Please don't wait. Please, please, please don't wait. Let the folks know you or your partner is pregnant. And please let us know as early as possible, because it's looking like when we start looking at the data, we want to treat with anticoagulation much earlier than previously thought. And there's a lot of precautions we do during delivery and pregnancy and postpartum for the woman. And yes, Dad, you too have a few things we have to do during delivery. AKA, we got to watch you and we got to make sure you eat and drink throughout it as well, because becoming dehydrated when your first baby is being born is not a good choice. The new CBS guidelines that are coming out will recommend no estrogen contraception, that intrauterine devices, IUDs, will be okay. Progesterone implants are okay. Depo-Provera is okay. Low-dose progesterone-only pills and condoms are all okay. And this is a change from any of the previous guidelines. They all just said no estrogen contraception. They didn't say what you could use. Exercise. So they're going to talk about exercise over there. I'm also going to talk about exercise because one of the growing epidemics in the United States and around the world is obesity. And one of the major ways to fight obesity is actually exercise and watching your diet. Exercise raises homocysteine in healthy individuals. Anyone read that? Anyone been told that? You've read that? No? You've heard it? Yeah, so it does. But interesting, there is no contraindication in exercise, at least in CBS deficiency. It's been studied. One of the few things that's actually been studied. Please do it. The U.S. recommendations for moderate exercise is 150 to 300 minutes per week. And if you're doing vigorous exercise, it's 75 to 150 minutes per week. For those of you who are trying to figure out what is moderate versus vigorous, it's easier to define what vigorous is. Vigorous is running very fast for a long period of time and things like swimming lots of laps. It will help your mind, your bones, and your weight. So please do it. Don't forget the strength training. So there's also been studies that look at cardiovascular work in individuals with CBS deficiency and strength training. Both are recommended and both have been shown safe as long as you work with your metabolic dietitian to make sure you get adequate protein. Choose what you like. I can tell you to exercise, but if you choose something you hate, you will not do it, right? I always tell my patients, I don't care what you choose something, all right? If you like to do yoga, I know you like to do yoga, then do yoga. You know, if you like to run, then run. If you like neither, find something. Even if you find a group of people to exercise with, because it's a group that keeps you honest, do that as well. Dietitians will help you adjust your diet to improve your goals and your healthy journey, because this is a journey through life. Which brings us to weight. Maintaining an appropriate weight is hard, whether you have homocystinuria or not. For those of you who have a dietitian, please work with them. Then we got to talk about weight loss because they're all over the news. GLP-1 inhibitors activate insulin, suppress glucagon release, and slows gastric emptying with a central appetite suppression. SGLT2 inhibitors prevent glucose reabsorption. Don't do this without your metabolic dietitian. Do not start this without telling your metabolic team to do it. Several folks around the world have started this and have had strokes as a result without working with their dietitian and their group. It has also been used safely in some individuals, but please don't start one without talking to your metabolic dietitian. When I was talking to one of my colleagues in Europe, they had 2 people do it. And when these people were asked, they said, well, I didn't think it would impact my homocystinuria. Okay. Please don't do it without help. Okay. Adult-related health issues. So we're going to define this adolescents up to 18, young adults 18 to 45. I know that's a big group. Sorry. Middle age is 45 to 64. Older adult is 65 to 84, and older adults are greater than 85. And you're going to say, Kim, really? You're going to talk about all these age groups? I am. Really am. So adolescents, so up to 18 years. I call this getting ready to take over your care or ready to launch, right? Can you name your diagnosis? Do you know how to get a hold of your metabolic doctor and, more importantly, your dietitian? Do you know how to do it? Do you know what medications you're on? Can you get refills and can you renew a prescription? Are you currently responsible for all of your meds, or do you need a system to keep track of what medications you're taking when you're supposed to take them? And what is your insurance plan? And what is the plan for when you turn 18 or 26, depending on your state and your location for your insurance? And do you need a guardian for medical decision-making or financial? Those are the important questions that everybody, and these questions should start to be worked on by 12. More. Adolescents have a lot of transition. If you're on a diet, can you make your diet and eat and make appropriate food? Can you cook? Have you ordered your low-protein food? Do you know who supplies your formula, and do you know how to contact them? Have you decided what you're going to do after high school? Can you do your own cooking, shopping, and laundry? Do you drive, or can you take public transportation independently? And does your physician take patients over 20, 22, 24, or 26 years? And if not, have you thought about transitioning to those adult doctors, that scary place that doesn't have stickers or lollipops, right? And I tell people that these are the important questions, but they're also important questions when you start thinking about children that do not have homocystinuria. And it's also kind of important for everybody to take these questions down. And the reason I say that is put it on your refrigerator, because this is where EMS looks for things like your med list and your doctors. So young adults, these are the 18 to 44. These folks are establishing a home of their own. That may be within their parents' household, that may be in a specialized center, or that may be in their home and home. They're finishing school and training. They're starting a job. And as I said earlier, everybody can start a job. They're thinking about having intimate partners and maybe even getting married. How many folks do we have here that now have children? People are starting their own family if they want to, right? And medically, your attention starts to split. You're starting to pay attention to your family and your job, and adherence gets harder. This is different than the problem we have in adherence in adolescents who are like, I want to be like everybody else. This is really an attention split. This is when you're trying really hard to do all those things and not paying attention to your life-work balance, and in this case, life-work medical balance. And there's actually no major changes in care outside of pregnancy care that we really see in this age group that would be different than what you were already doing. And honestly, there's clear data that HCU complications, including blood clots, are more likely related to non-adherence in this population. And this is where we start to really see these start to make a jump. So if you look at blood clots risk across the population, there's a bump in young adulthood. Middle-aged. So this is our 45 to 64-year-olds. These folks start to really, this is really when you start to see the age-related illnesses increase across the population, but also within homocystinuria. And these include hypertension and diabetes and hyperlipidemia, right? So you start adding on to what you already have. And there might be an increased risk for osteoporosis. So we know that CBS deficiency has an increased risk of osteoporosis all the way down into the adolescence. But then as especially women start to go through menopause, their estrogens fall and their osteoporosis and risk goes up. We also see this in men because they go through a little bit of a menopause as well. Women will have perimenopausal pause and postmenopausal with symptoms. And we don't have great ideas of how to treat these symptoms. I'm sorry for those who are of that age, in part because we hadn't ever thought about what are we going to do with when people turn 45, 55, 65 and start to have menopause. Don't let your PCP blame everything on homocystinuria. Please, 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 please. If your sugars are high, it's not your homocystinuria most of the time. You should undergo the usual breast, colon, and prostate cancer screening that are appropriate for your age, okay? Just because you have homocystinuria, we do not think that alters your cancer risk. Immunizations to avoid pneumonia, influenza, and COVID are important, especially if you have homocystinuria, because those things often have blood clots as one of the complications you can have with a severe case. You may need a pertussis booster, and people say, what is that? That's whooping cough. Most people get vaccinated as children. Immunity starts to wane as you get older, and we've discovered that with immunizations, immunity can wane in the 45 to 64-year-old, and you don't want to give your grandkids whooping cough before they can get vaccinated. And please don't forget your tetanus booster. That's lockjaw. Old age. These are 65 to 84-year-olds. So you continue to have growing adult complications and health issues. Do not allow homocystinuria to be the answer for everything that ails you. Make sure it's not related to ordinary age stuff. This includes memory problems, Parkinsonian disease, chest pain, joint pain. You should undergo the usual cancer screening and immunizations as are recommended for the age group. And then our old age, the greater than 85-year-olds, we have no idea how homocystinuria impacts these ages. Just keep it up. I have every hope that we will have a bunch of 85-year-olds here soon. What does adulthood bring us? An increased risk for thrombosis with non-adherence. And non-adherence is usually you get distracted. You've got other things. Increased risk for depression and anxiety. The studies are clearly showing there's more depression and anxiety in individuals with homocystinuria than the general population. And these need to be treated appropriately and recognized. And then an increased risk for osteoporosis. Homocystinuria adults can enjoy long and healthy lives. I like to point out, we're talking about greater than 85-year-olds. In 20 years, I want to talk about the greater than 100-year-olds, okay? The ultra olds. And please work with your metabolic team. Working with your metabolic team kind of changes. We become much more partnerish. Some things that are changing in health policy now. And what now? So there's a new Medicaid work requirement, 80 hours of volunteer work per month unless you get an exemption. Medicare still doesn't cover formula if it's not entirely G-tube fed. That has not changed. ERT home infusions are not covered by Medicare at this time unless you are homebound. So if you are getting an ERT, then you can get it covered in an infusion unit, but you cannot get it covered at home, as I said, unless you're homebound. And this is becoming actually more of an issue now that we potentially have some ERTs. And reproductive health laws differ from state to state. This impacts hormone therapies, including birth control, insurance for adults. It's complicated, and most therapies are expensive, and that layered coverage really helps. You can You might still qualify for Medicaid. Medicare Part D is the drug one. And private insurance with commercial plans vary according to their coverage. If you're having a hard time paying for your medications, there's four groups of folks that will help pay. This includes the Healthwell Foundation, the Good Days Foundation, National Organization of Rare Disease, and then some manufacturer specifics. At this point, I want to have a conversation. So I would argue we have about 7 minutes, and then we can do a 15-minute break. But let's have a conversation because I see a lot of adults. I see some people nodding. Let's hear some questions. Let's have a conversation about what makes adulting hard. What makes adulting hard? Did I cover most of it? Come on. Insurance makes adulting really hard. And figuring out what your insurance policy covers and the fact that it changes January 1st. Does everybody know, even if your insurance doesn't change, the policy changes January 1st? Did anyone know that? Yeah, they all change a little. Insurance is awful. You have to look at it. You have to determine whether or not you qualify for federal coverage, state coverage, a little less as adults, and you're private. What else?
One thing you and I chatted about yesterday was that we're learning now. Carson's turning 19, and he's seen the same genetics team his entire life. It's a children's hospital. What happens when they become an adult?
Mm-hmm.
And general assumption is, there's got to be a genetics clinic that focuses on adulthood, and there isn't.
Yep.
And so,
depending on where you are, yeah.
Yeah, and so basically we've come to the realization that Carson will continue to see his genetic doctors at the Children's Hospital in Kansas City until there's another alternative that's available.
Yeah.
And so even though I think Danae even said that she saw her pediatric genetics until she was 35. So that was kind of eye-opening for us.
Yeah.
But it's a success story because it means that in the past there wasn't a need to have doctors caring for this because kids weren't making it to adulthood. Now they are.
Yeah,
So it's kind of a lesson.
it's complicated. You want to comment about that?
So with the transition, keeping like I have my genetic, I'm a life coach for children, and like having had to endure medical pieces in the adult side, I was told, I don't know if this is across the board, but I was told that when you go in, even if they see like there's other doctors on your list, or even if you have other specialties within that hospital, if you're going in like for an emergency case, they won't necessarily contact them directly. They might like let the office know you're there, but there's not like direct contact. So you have to advocate as either your parent or yourself.
Your patient.
I want you to contact this doctor and let them know I'm here.
I tell my older individuals and my adults, so the US is terrible about transition in terms of metabolic and genetics. Just to make everybody feel well, to be a boarded medical geneticist, you have to take prenatal to grave, which means my oldest patient was 87. Now, granted, I'm also an internist, so this was not at the end of the world, but the hospital would only admit up to 26, which becomes a problem. I tell people you need to know what your metabolist's phone number is or your geneticist's phone number is, and you need to know how to call the doc on call. Because if there's an emergency, you may actually have to be, or your partner or your caregiver has to be the person that puts them on the phone and gets them on the phone and then says, hey, talk to this person. Because I've had ERs pay no attention to my ER letter. You know why? It's a children's hospital. So, and that's just the reality of it. And it is a success story. And it's complicated because there's only 120 boarded metabolists in the United States that see kids. I'll say that again. There's only 120 boarded metabolists in the United States who see kids or adults at all. let alone adult specific. And so a lot of hospitals do not have an adult specific metabolist because there just isn't. Now, the success story means that I'm trying to figure out how do I split myself so that I can also go to the adult hospital. We have not yet figured that out. I do know I cannot clone myself despite being a geneticist. All right. So, do you need two of me? So yes, that is a huge issue. Is that we've gotten really good with getting people through that stage that we had not before, but that doesn't change the challenges for everybody. And since I'm bored in internal medicine, this is 20 some years ago. Please don't do the math. When I was in internal medicine residency and I had made the decision I was going to do medical genetics, and I had a cardiologist look at me and say, Kim, why are you going to do that? You're such a good internist, and genetics is only for kids. Okay, so there's also a problem that on the internal medicine thing, they say, oh, they can't possibly have a genetic disorder. That's just for kids. So there's also an education component that's really hard. And that's something where you all can really help, is advocating in internal medicine or adult care that these disorders aren't just for kids. Kids grow up and adults are diagnosed with these disorders.
When I was diagnosed, I won't say when, I remember my mother being told that I would not survive to see my 30th birthday. And of course, she died to school and for better education. But yeah, so I would still say child disease, not you don't need to worry about this child disease. So I want to go like once I have a good endocrinologist and internist.
Mhm.
My
Yeah. It's complicated, yeah. It's complicated. It's we've gotten really good at taking care of people. Now we have a hard time getting folks transitioned, and this includes primary care. That's absolutely it. And I'd like to point out the oldest of the old, so our greater than 85-year-olds, I have every expectation we'll start seeing greater than 85-year-olds. Because there's no indication that homocystinuria at this time will shorten your lifespan. If you've been fairly healthy up to this point, more than you would expect for the average. So those numbers keep going up and up and up, and what the average ages are. Yeah.
About a little extension on your doctors that you might have been seeing your whole life. Keep track of how old they are, because they might start retiring on you when you become
Yeah. Remember, there's only 120 metabolists, and unfortunately, the average age is 63.
Are there more coming in the pipeline to the medical system, or are there still some?
We're not replacing as fast as we're losing. So if somebody that really wants to become a metabolist, please encourage them to do so. If that's a pediatric resident you see, if that's an internal residence, please encourage them to do medical genetics, because sometimes it's a patient that gets you started. For the country. Mm-hmm. Mm-hmm. So encourage your family, your friends. We did a survey at the SIMD, kind of an unofficial survey, and tried to figure out where people came from that went into metabolism. You've got the children of metabolists, that's one group, or geneticists. You've got individuals that have an MD, PhD, that's a second group. Third group is individuals who have family members that have a genetic or metabolic disease. And then the fourth group are individuals of underserved settings. This includes financial, and then individuals of underserved ethnic backgrounds. Those are the four places you're getting your metabolists right now. This one. That one.
And can I have a question about that?
Mhm.
The no estrogen contraception, has there been any studies about that with carriers?
No, there's actually been no studies about that with folks with CBS deficiency either, although there's a number of reports of getting thrombosis with homocystinuria. So the answer is not really. The studies that have been done that look at increased thrombosis are looking at common variants that you see in the population with CB that in the CBS gene, in the MTHFR gene, and in the MTR gene, so cobalamin G gene, and it's kind of mixed about whether those variants put you at an increased risk of having thrombosis. Those particular variant polymorphisms are really common in the population. So depending on which population group you look at, it will either show an association or not as a carrier. But individuals with known pathogenics, there's never been a good clinical trial to look at carrier risks. Did that kind of answer your question? I'm being told to hurry.
No, not, there's no connection as of now.
There's no data. There's no data. All right, I've been told I'm supposed to send you all on break. Danae's going like, go. All right. Hopefully that was helpful, guys.